And then we're going to just start right in with a case here that's a real case that's from the University of Kansas Hospital. And it's a good place to start. It's always good to start with patient care, I think. So that's what we'll do. What I want you to do is think about this case. Think about what would you do if this guy showed up at your hospital, and then we're going to ask some questions about him. So this was a 72-year-old guy whose wife brought him to the emergency department because of flank pain and fever. Or actually, she brought him in because he had some mild confusion. And he's normally not confused at all. He is a banker. He works every single day. So this was disturbing to her. His past medical history is significant for coronary artery disease and hypertension. And also, we know that he's had a ureteral stent placed on the left previously for some sort of stricture or stone. She isn't clear what that was. His medications include terazosin for his prostate, atorvastatin for cholesterol, and metoprolol for his high blood pressure. His blood pressure in the emergency department is 105/43. Pulse rate is 117. Respiratory rate is 22. Temperature is 39.1 degrees Celsius, which is, I forget what that is in Fahrenheit. Do you guys use mostly Fahrenheit or Celsius degrees? Fahrenheit. Okay, well, I'm sorry, I haven't worked that out, but that's something north of 101.5. Yeah, it's a little more than 101.5, but I don't have that worked out. And what I'm doing here is trying to get so that my arrow stays put the whole time that we're doing this. O2 sat was 87% on room air. By physical exam, there wasn't too much. He did have benign prostatic hypertrophy, but then when you pounded just slightly at his left costovertebral angle, he just about jumped off the table. So that's what he had. Now, I think these signs, these symptoms, most all of us will feel fairly comfortable acquiescing to, yes, this is an acute pyelonephritis. So the question is, what would you do with him in your hospital? And then I will ask you to answer a question here. So the most appropriate course of treatment for this patient, based on the available data, is what? You give him some oral levofloxacin and discharge him to home. Give him some oral levo and admit him to the hospital. Give him some IV levofloxacin and admit him to the hospital and maybe give him 150 an hour of normal saline. Or you give him some IV levofloxacin, 2-liter bolus of normal saline, and transfer him to the ICU. Or I give this talk in smaller hospitals too. Or you transfer him to a larger hospital so he can go to the ICU. Think about that for just a second, and then I'll tell you. The correct answer in this gentleman is the last one, the aggressive option, and all the information that you needed to make that decision was present on the first slide. If it doesn't seem like it was present on the first slide, I hope that as we progress through this talk, it will make more sense. And that's the point of the whole talk, is to help you to see the information that was there. Now, follow-up information on him includes that his white count was high with 33% bands, platelet count was low, he's got acute kidney injury, he's got thrombostasis problems, his D-dimer is elevated, and his lactate is high. Urinalysis was not yet available at that time in the emergency department. But none of this information on this slide was necessary for the decision. And so that's what we're going to go into over the coming minutes. This is what I call this talk. I think I'll just zoom past that. Here's a good question for you, though. How many people do you suppose in the state of Kansas develop severe sepsis every year? Think about how many you see. Think about what you might think. 500, 1,500, 5,000, or more than 10,000. Well, the actual answer is that it's more than 10,000, and in fact, at the rate of compounding of new cases, which we'll go into shortly, we think it's somewhere in the range of 20,000 cases of severe sepsis in the state of Kansas every year. Now, mortality risk from severe sepsis ranges from 30 to 50% unless a hospital is doing specific things to attempt to improve on that mortality. So you can imagine that means a fair number of people just in our state are dying every year from severe sepsis. Severe sepsis is the major cause of morbidity and mortality worldwide. If you stop and think about that, you'll realize that it's because so many people in the world don't even have antibiotics available to them. So if they come down with an infection of just almost any sort, it's left to their body's defenses, and infection is a major cause of death, perhaps the major cause of death worldwide. However, closer to home, severe sepsis is the leading cause of death in intensive care units. Doesn't matter what it was that took you into the intensive care unit. Might have been a GI bleed, might have been post-op after one surgery or another. It might have been, say, a COPD exacerbation. Just doesn't matter. The thing that's most likely to kill you in that ICU is severe sepsis. This data that I'm showing you here was actually published in 2001 by Derek Angus, but it comes from government records from 1995. And that's going to turn out to be important as we go along here. So that's why I want to point out that the data actually comes from 1995. So at that time, pardon me, 1995, there were more than 750,000 cases of severe sepsis in the US that year. What that equates to, because of the high mortality rate, is that year, more than 500 patients a day were dying from severe sepsis. Our estimates based on 1995 data were that for the state of Kansas, given its population in 1995, that probably meant between 6,000 to 8,000 cases a year of severe sepsis and something like 6 to 8 patients a day dying. And you will see that those numbers have gone up. So the answer is more than 10,000. Here's a good question for you. The in-hospital mortality from severe sepsis is 300% higher than that from acute MI. True or false? Well, those of you who are good test takers will say, well, obviously the answer must be true, because otherwise why would he stick it in a talk here? And that, of course, is true. Severe sepsis is fatal 30 to 50% of the time. In-hospital mortality from acute MI, even at its worst, is 14.5%. This was the in-hospital mortality back when I was an intern, back when all we did with people with acute MI is put them in a bed in the CCU for a week on a monitor and basically not let them move. At that time, this was our mortality. We don't do that anymore. Since then, actually, fortunately, right at the end of my internship was when we got thrombolytics of various types. And we know that the in-hospital mortality, if you make it to the hospital and get your thrombolytic, your in-hospital mortality was cut to 9%. And then subsequently, if you happen to go to a hospital that has angioplasty and can place stents, then your mortality is 7.4%. And actually, I just saw some more recent numbers in December that suggest we may have taken that down to about 5% now. So quite clearly, this is true. Severe sepsis is going to kill you 30 to 50% of the time in hospital. And so that is at least 300% higher than MI at its worst. This slide shows numbers of deaths. Again, this is the 1995 data that was published in 2001. This slide shows numbers of deaths from various different disease processes. Now remember, in 1995, AIDS was uniformly fatal, and we've made substantial improvements there. Breast cancer deaths in that year here, and acute myocardial infarction and severe sepsis running neck and neck for who killed the most people in 1995. And in truth, at least half of the cases of severe sepsis that are out there are fail to be diagnosed and do not show up in the administrative data. So probably severe sepsis, even at that time, was killing more people than acute MI. It's not just how many people it kills in the hospital, though. And actually, I have two slides here to illustrate this point. But it is like this. This is multiple studies done since about 2000 that have looked at long-term mortality from severe sepsis. So obviously, it's not just important whether it kills you while you're right here in the hospital, but what's its long-term effect on you. The size of each of these symbols is related to the size of the cohort that's being studied. So you see these big orange blobs here. This was the largest study, and some of these smaller little crosses were some of the smaller studies. But in all of them, you can see that the mortality from severe sepsis doesn't just stop at the hospitalization. And so here we have a median mortality of about 35%. That median for how many people are dying goes up over 3 months, 6 months, 1 year, 2 years, 3 years. Here's another way to show that. So here we start with hospital discharge. So we say everyone on this particular graph made it to leave the hospital. The mortality in these studies goes as high as over 50% over the next 2 years, all related to severe sepsis. And the thought is that the total body inflammation that is engendered by severe sepsis persists in causing problems. In fact, one particular problem we know is that if you have severe sepsis and are discharged from the hospital, you are 1.5 times as likely to die from acute MI in the coming year as someone with your same age and risk factors who didn't have sepsis. So that inflammation that gets activated has persisting effects. And it's not just dying either. This is a study published in 2010 looking at cognitive impairment among survivors of severe sepsis. Now, the study, it was an interesting study. It actually starts studying people at about age 55 with cognitive testing so they can find cognitive impairment, and it tracks them through until death, doing these cognitive studies every 2 years. It's called the Health and Retirement Study. So some folks who were interested in sepsis came and said, let's look at your data and compare with when someone gets admitted to the hospital. So you can see the second survey before sepsis, and the last survey before sepsis, and this is mild cognitive impairment, is in about 7.5%, and moderate to severe in another 7%. Look what happens to your survey after you've had sepsis. So about the same number of mild and a whole lot more moderate to severe, and that seems to persist for another 2 years to the second survey beyond sepsis. Another way of looking at this that I find rather frightening is this. So if you're going along in the triangles here where you have no cognitive impairment in the third, second, last survey before sepsis, what happens to you after you have sepsis? Bumps you up to the category on average of people who had mild cognitive impairment before they ever got sepsis. And if you were in the mild category, the circles, and you get sepsis, bumps you up in terms of cognitive impairment to the level that would be considered severe cognitive impairment. So just having the sepsis does that to people. We have placed a lot of emphasis in the past, those of us who do intensive care medicine, on getting people to survive till they can get out of the ICU. And then we learn getting people to survive until they get out of the hospital. But I can tell you in the last 5 or 6 years, I have spent a lot more time thinking about it's not just being alive, breathing, and having a heartbeat when you leave the hospital that counts. The whole purpose of doing intensive care. The whole purpose of us having people in the hospital is to help them to return to those things that they love doing outside the hospital. And so you can see from this slide and others that we have not done a stellar job of that with people who have severe sepsis. The only way we believe that we're going to make a dent is for us to pay attention to some of the things that I am showing you here today and to treat very early and very aggressive to get that done. What segment of the population do you suppose is at the greatest risk for severe sepsis? The baby boomers, Gen X, Gen Y, patients on chemotherapy, perhaps. Well, while you ponder that, I want to show you this graph here, also from the 2001 paper and also data taken in 1995. So what Derek Angus did on this particular graph is divide into 4-year age groups. So going along here, people are getting older. Then on the right, he plotted the incidence, which meant number of cases per 100 or per 1,000 population. And on the left, plotted absolute number of cases. So the first thing that you notice on this graph as you look is that incidence of severe sepsis kind of slowly rises, slowly with age, but not too terribly much until what? Until you hit about age 65. Then between age 65 and age 80, the incidence of sepsis in the population actually triples. So your risk of getting it is tripled over that coming 15 years. Now, the second thing to look at, and I'm the only one that I ever hear talk about this, but I think it's very important, is this. If you look right in here, you'll see this age group in here between 35 and about 50. You see a rather large bump in the number of cases without seeing such a large bump in the incidence. So one day I was looking at this and I stopped and asked myself, why would that be? How can it be that you have a large bump in the number of cases without a large bump in the incidence? Well, the simple answer is this. Oops, I apologize. Let's get back to that. The simple answer is this, that that you have to have a whole lot more people. Since incidence is the number per 1,000 people and number of cases is just the number of cases, you have to have a whole lot more thousands of people if this big bump in number of cases is not going to increase the incidence simultaneously. So then I stopped and asked myself, this data was collected in 1995. We're talking about people that were 35 years old to about 55 or 50 years old in 1995. So how long ago was that? Well, at the time I was thinking this, that was about 15 years previously. So I go, okay, so if I take people who were between 35 and 50 in 1995, what happens then if I move them over here? The leading edge of that group suddenly hits 65. The leading edge of that group suddenly hits where the incidence is going to go up like a rocket over the coming years. And who are these people? These people are me. These people are some of you. These are the baby boomers. Now, here is the interesting thing. Well, no, I'll show you on the next slide what the interesting thing about this is, or one of the interesting things about this. But we know that baby boomers are now turning 65. It's almost 20 years after 1995 now. So this big bunch of people has now moved over here where the incidence is climbing to the sky like a rocket. So my estimate is that the segment of the population at greatest risk for severe sepsis is the baby boomers. Now, we all know, and some of you may have chosen choice D here, that patients on chemotherapy are at high risk of dying from infection. In fact, statistics show that 48% of people who have cancer die from severe sepsis. And by the way, those deaths are recorded as cancer deaths in most cases and not as severe sepsis deaths, which is one of the reasons that we underestimate severe sepsis deaths. So, patients on chemotherapy clearly are at high risk, but in sheer numbers, the total number of baby boomers far, far outweighs the total number of people who are getting chemotherapy. And that's why I say the baby boomers, I think, are the population at greatest risk. Now, sepsis incidence was going up before the baby boomers started turning 65. So this is a study done by Greg Martin and colleagues. Greg is working in Atlanta. He was born and raised in Wichita, Kansas. So I like to point out when Kansas folks have done good things, and this is one of them. Greg was working with investigators at the CDC to see what's been happening to the incidence of sepsis over the preceding 20 years. This paper, of course, was published 10 years ago now in the New England Journal of Medicine. What he saw was that the incidence of sepsis was going up by a compounded annual rate of 8.7%. Imagine that, 8.7%. I wish my retirement account were growing at 8.7%. I'd be a happy man. Well, here another colleague of ours, Victor Dombrowski from Pittsburgh, repeated that study beginning in the decade from 1993 to 2003. Now, why did he go for that decade? Was because the definitions that we now use for diagnosing severe sepsis were published in 1992, and I think he hoped to find what was the effect of having those published criteria on incidence of sepsis in the US. What he found using US government records was an annualized increase of 8.4% on average over that 10-year period. So what does that mean? What does that mean in terms of numbers of cases? If anything that you have is compounding at roughly 8.5%, that means the doubling time. How long does it take you to double your money in your retirement account? How long does it take to double the number of cases of severe sepsis? Is right at 8.5 years. So let's think about that and what it means about the previous graph for a moment. So large numbers of people. We had 750,000 cases, 750,000 cases in 1995. 8.5 years after that, 2003, should have doubled to about 1.5 million. 8.5 years after that, somewhere in 2012, should have doubled to about 3 million. And the most recent population-based sepsis estimates that were published in Critical Care Medicine last year suggest somewhere in the range of 1.5 million to 3 million people in the United States get severe sepsis. Matching falls just in line with frankly, what I've been predicting since 2003 when Greg Martin published this study, that we should be having about 3 million cases by now. This increase was going on before the baby boomers started to turn 65, which is just astonishing to think about. Remember that the baby boomers in April of 2011 began turning 65 and began turning 65 at the astounding rate of 10,000 of us every single day. Imagine that. 10,000 new people hitting age 65 every single day, and it's going to go on for 19 years. Going to inject 39 million people above the age of 65 into our population. Now, when you add to that they then are reaching the part of the sepsis curve where sepsis becomes strikingly more incident, I think sepsis is going to dominate the landscape of medicine in the coming 20 years. If you're just coming into practicing medicine, you are going to see so much sepsis that you should, I hope, know it like the back of your hand, but it's going to dominate the practice of medicine regardless of your specialty. So All this stuff about how many cases of sepsis, let's talk about what sepsis is. The first thing to start with is what sepsis isn't. Sepsis is not equal to hypotension. You will see that hypotension is a feature of severe sepsis, but it is not the defining feature of severe sepsis. The second thing is sepsis is not equal to bacteremia. You do not have to have proven bacteria in the bloodstream. We're not certain that you ever have to have bacteria in the bloodstream in order to have severe sepsis. These are two common misperceptions, that you have to be hypotensive, you have to have bacteria in your bloodstream. Both are not true. Bacteremia would define an infection that could give you severe sepsis, but you do not have to have bacteremia to have severe sepsis. So what is severe sepsis? These are the accepted criteria that we've been using now for 20 years, that were published in 1992 in Chest and simultaneously in Critical Care Medicine. The criteria that we're going to run through here, I will spell out in more detail on the next couple of slides. Criteria number one is you have to have infection. You will see when we get to systemic inflammatory response syndrome, or SIRS, that a lot of different things can give you SIRS, but we need to be talking about an infection. It does not need to be a proven infection. You have to have a reason to believe that the patient is infected. Now, before I jump to that, let me just say this is probably my favorite definition, short definition of an infection, I think, is the invasion of normally sterile tissues with some form of microorganism. By the way, I want to take this time right here to say that it doesn't matter what the type of microorganism is. Bacteria, we all know. Fungal infections are becoming much more prevalent in the intra-abdominal surgery post-op patient, far more so these days than even bacterial infections. And then viral infections also cause severe sepsis. In fact, all the people you read about with H1N1 influenza, nearly all of them, well, all the sick ones that we read about, have severe sepsis induced by that viral infection in their lungs. So it can be any sort of microorganism that's invading. So infection is the key component. Oh, and I was going to say that it doesn't have to be proven. For example, if the patient comes into you saying, I developed this high spiking fever and sudden onset of pleuritic chest pain on the left, and I'm coughing up this ugly looking stuff that's somewhat purulent and somewhat blood-streaked. You listen to the patient, you hear bronchial breath sounds on the left or the right or wherever you hear them, and you say to yourself, this is pneumonia, got to get this patient treated. That's sufficient suspicion for infection. You don't have to have bacteriologically proven in any way. Now, infections we get all the time. I always joke about teenagers who develop small little micro-infections on their face, infections that they believe are going to kill them, but in point of fact are not. These infections don't cause any systemic symptoms, and they go away and are self-limited. On the other hand, when we get a more severe infection, we develop what's called the systemic inflammatory response syndrome. This is a body-wide response, and it can happen to a variety of processes. And I'll list some of those here shortly, but it can happen in a number of cases. We say that you have SIRS, or systemic inflammatory response syndrome, if you have at least two of the SIRS criteria that are going to be on the next slide. Sepsis is when a person has an infection plus at least two of the SIRS criteria. This is not the 30 to 50% mortality sepsis. This is more like the under 10% mortality sepsis. But as I often say, I think if I had a 10% risk of dying by getting in my car and driving home in the afternoon, I would probably find some other way to get home. 10%, nothing to sneeze at. On the other hand, it is not the 30 to 50% mortality that we see with severe sepsis. So what is severe sepsis? It's when we have this, plus we diagnose at least one organ dysfunction, which will show up in a couple of slides how we look for those things. 30 to 50% mortality if you develop at least one organ dysfunction. Septic shock is what so many people have in mind when they use the word sepsis. This, though, is sepsis. Septic shock is when you have sepsis that makes you hypotensive and it doesn't respond to getting IV fluids, or it requires IV vasopressors in order to bring the blood pressure up. Mortality risk here historically has been 60 to 80%. So what is SIRS? Systemic Inflammatory Response Syndrome. SIRS is, first off, it's non-specific response to insults. What kind of insults can do this for you? Very commonly, pancreatitis will give a person SIRS. Very commonly, burns will give a person SIRS. Very commonly, multisystem trauma. In fact, you will see in a moment, we'll come back and I'll show you how people who come from the operating room nearly always have SIRS. So let's talk about what is SIRS. Temperature of more than 38 or less than 36 degrees Celsius. In Fahrenheit, that would be more than 100.3 or less than 96.8 degrees Fahrenheit. A heart rate that's more than 90 beats a minute. A respiratory rate that's more than 20 per minute, and a white blood cell count that's more than 12,000 or less than 4,000, or that has more than 10% band forms or other immature neutrophils. So first thing to say is these are our criteria in patients who are age 14 and up. There are separate criteria for those of you who take care of children, separate criteria that are age and weight based that are published in the journal Critical Care Medicine and are available. I don't have those committed to memory though, because I'm an adult intensivist and so I don't see children, and I apologize for that. A couple of important things to say about this. That white count less than 4,000 actually has been demonstrated. Again, and I'm sorry, I should say this is a white count that goes below 4,000 because of the infection, and we're not talking about somebody who has pre-existing neutropenia from their chemotherapy. Here we're talking about someone who has normal white count that goes down because of the infection. This has been associated with actually a higher mortality than having a high white count. So if you have any two of these, you have SIRS. And in the presence of infection, that SIRS becomes quite important. Acute organ dysfunctions, simple way to do that is head to toe. Altered consciousness, confusion, or psychosis. These are easy when it's, say, grandma brought from the nursing home who's obtunded. Well, it's easy to tell when someone's obtunded, so easy that they could tell at the nursing home and call the ambulance and get them brought to the hospital. A more subtle finding here that I like to use is to ask someone this question. Now, I'm going to ask you all this question, and I want you to think about how long it takes you to come up with an answer. Simple question. What is your address? You've all thought of it by now. You all know your own address by now. One of my favorite questions in the ICU is, sir, what's your address? And if I get this halting answer of, or, and ultimately he spits out Kansas City, I know that there is central nervous system dysfunction going on because I know that that man knows his address, as we all do, and it should take a couple of seconds to spit it out. Cardiovascular dysfunction is denoted by hypotension. And what's our definition of hypotension? Systolic blood pressure less than 90, mean arterial pressure less than 60, or we have now changed this criterion to be 70, and I just haven't changed my slide yet. Or what if you are the guy's primary care provider and you know that this Mr. Smith runs around with a blood pressure of 180 all the time because he just won't do the stuff that you're asking him to do for his high blood pressure? And what if he presents in the emergency department with a blood pressure of 120? If there's a drop of more than 40 in your systolic blood pressure, we call that hypotension, and it is hypotensive for him. The other place where we see this fairly commonly is the person who's been rocking along with a blood pressure of 140 in the hospital and now drops to 100 one night. That is hypotension. With regards to the lungs, we are talking about hypoxemia. You can say it any way you like, a PO2 less than 70, an O2 sat less than 90, or a PaO2 to FiO2 ratio less than 300. This is something we use in the intensive care unit, a fairly large amount. The only time we don't use hypoxemia as a marker of organ dysfunction is when the patient has pneumonia. Because if you stop and think about it, you'll recognize that pneumonia is a circumstance where you put pus in your lungs. You put pus in your alveolar space, you are entitled to have hypoxemia because your alveoli just can't do their job that way. Whereas other organ functions that we're looking at are organ functions distant from the involved organ, such as if you've got pneumonia, is there any reason you can think of other than systemic effects that you should get oliguria, anuria, or a bump in creatinine from having a pneumonia? Only if there is system-wide, body-wide inflammation and the effects thereof. Notice that we are only looking for a bump in creatinine of 0.5 milligram per deciliter. Just to put that in perspective, there are many young women listening to this talk right now who probably only have a creatinine of 0.5 milligrams per deciliter at baseline. A bump of 0.5 in them would mean what? Regarding their kidney function, regarding their creatinine clearance, it would mean that it had been cut in half. So that's rather substantial. Even those of us guys who have a creatinine of 1, a bump of 0.5 would mean a 30% hit to our kidney function, which is substantial. For liver dysfunction, we look at a bilirubin. This criterion goes back and forth in the literature. The most recent that we see is a bilirubin greater than 4 that's induced by infection. Thrombostasis. A lot of people don't think of blood clotting as an organ. It isn't exactly an organ, but we count it as one because what are we actually talking about here? We're actually talking about disseminated intravascular coagulation, which we all learn in medical school or nursing school. They teach us about the most horrible complications of that, the patient who's bleeding from every orifice, or the patient who, on the other hand, is clotting arteries from the other manifestation of DIC. But DIC comes in much less dramatic manifestations, such as thrombocytopenia, such as an elevated D dimer, or just an elevated PTT. So we look for evidence of thrombostasis as an organ dysfunction. 90% of people with severe sepsis actually do have an elevated D dimer if you choose to look. And then last but not least, lactic acidosis. The final common pathway, as we understand it in sepsis, or as far as we have it worked out right now, is microvascular blood clotting. DIC, basically. And what do we mean by microvascular? We mean blood clotting at the capillary level. We mean blood clotting that when it happens, it stops blood flow through a capillary and keeps the cells that are supplied with oxygen by that capillary from getting oxygen. When enough of those cells are starved for oxygen, when they begin to metabolize anaerobically, as they do, and release enough lactate that it can be found in the bloodstream and causing acidosis, that's a lot of cells in the body that are lacking oxygen. And so we consider lactic acidosis an organ dysfunction just as if it were one of these other organs that we're looking at. Now, you should know that for every one of these organs that dysfunctions, the risk of dying goes up by 15 to 20%. So multiple dysfunctional organs add up substantially to high risk of death. Now, I put this slide up for one specific reason here, and that is what we just went through is lacking something. And what is it lacking? Why is it hard for people to diagnose severe sepsis? Conceptually, you're probably thinking it should not be hard. What you just told us is all easy to look at and diagnose, and that is absolutely correct. But we have this little foible as human beings, actually, and that is we like for the answer to be yes or no. So let's talk about that for a moment. If a patient comes into the emergency department with acute substernal chest pain, what do you do for them immediately? I know from personal experience that within 5 minutes you've obtained likely a bedside troponin and an EKG. You've done those two things because if either one of them, if you see elevations in troponin or you see ST elevations, then you know that myocardial injury is present. Infarction is going on. You do that fast so you can either get the thrombolytic or get them to the cath lab because that's going to save lives. Easy peasy. Answers yes, get them in. Answers no, okay, then we can spend some more time working this out. Sepsis doesn't come with that test or marker. We just don't have it yet. And therefore, we have to use our noggins and we have to go, is there infection? Is there SIRS? Is there organ dysfunction? That's 3 separate steps. And the problem with us as human beings is we just don't like doing that. We like these binary answers. Yes, no. Yes, no. Positive, negative. It's just what we like as human beings. It's not right or wrong. It's just who we are. Going to skip a couple of slides here, which you would be able to look at if you chose on your own later. I have sent these, at least I think I sent these out to Carrie and Julie and Melinda Lair at the AHEC so that you've got them to look at, or they can get them printed off if you like. So if you've been listening, you should get the answer to this. Diagnostic criteria for severe sepsis include positive blood cultures and hypotension, positive blood cultures and tissue hypoxia, positive blood cultures, SIRS, and lactic acidosis, or suspected infection, SIRS, and organ dysfunction. And obviously, you all listened well, so you all get that the answer is suspected infection, SIRS, and organ dysfunction. Now, would any one of these people likely have severe sepsis? Yes, because they've all got infection. Hypotension is an organ dysfunction. Probably regardless of the SIRS here, we're going to say if it's hypotension caused by infection, yeah, that's severe sepsis. Tissue hypoxia is exactly what we've been describing, and SIRS and lactic acidosis. So the point is, all of these people would be septic, but you don't have to have these things to define sepsis. So let's go back to our, oh no, I wanted to say one more thing. I guess I'll skip this, then we'll go back to our man here. So what are we talking about here? Why do I show this man? I show this man for 3 reasons that I'll go through very quickly. Number 1, He's the guy that trained me in severe sepsis. Okay, so I owe him the mere fact that I'm doing a talk about sepsis is owed to Roger Bone. Number two, Roger Bone is the man who developed all these criteria we just went through about severe sepsis. And then number three, this is the really cool thing. When Roger Bone developed these criteria, he was working as an assistant professor at this university, the University of Kansas. Right down the hall from where I'm sitting now is where Roger Bone sat and thought and worked out these criteria. And I don't have time to go into why he did that, but the point is, he was the guy who recognized it can't be about blood cultures because, holy smokes, those people, if I wait for the blood cultures to be positive today, that came to me sick yesterday. That just can't be it. So that's why and how he came to do those. These criteria are used internationally, and they all started right here in Kansas. Let's go back to our man. Our first man. I want to run through this guy again. And obviously, when we're live, I can ask for your responses here, but I want you to think, do we think he has an infection? Well, we agreed when we first went through that we think he has pyelonephritis. Does he have SIRS? Well, what do we look for SIRS? We look for pulse rate. Oh yeah, that's high. That's one. Respiratory rate. Yeah, that's above 20. That's one. Temperature. Oh yeah, that's above 38. That's one. So he has 3 out of 4 SIRS criteria and an infection. So he has sepsis. That much we know. Next question we have to ask, does he have organ dysfunction? Now, what do we see here? Well, why was he brought to the emergency room? Because the banker who works every single day is mildly confused. He's got he's got central nervous system dysfunction. His O2 sat on room air is 87%. He's got hypoxemia. And then the last one is a little more subtle, but his mean arterial pressure here is 63 millimeters of mercury, which is low. So he has 3 organs dysfunctional just on this slide. His calculated risk of dying based on that 15 to 20% per organ, 45 to 60%. That's frightening. If you think you want to send him home, or you think you want to put him out on the floor with just some saline running, you'd best think again. He has a high risk of dying and he needs to be put where we can really watch him. Then when you add in, there's your 4th SIRS criterion, but here's your thrombostasis is out. That's another organ. Here's your BUN and creatinine are out. That's a 5th organ. Here's your lactate is elevated. That's a 6th. So any way you look at it, this gentleman has 6 organs down, 15 to 20% risk of dying per organ. So his risk of dying calculates at 90 to 120%. Wow, that's frightening. Really? We're going to put this guy on the floor? I don't think so. So all of this stuff about how to find severe sepsis would be for naught if there were nothing that we could do for severe sepsis. But there are things we can do. Initially published in 2004, revised in 2008 and 2012 are the Surviving Sepsis Campaign Guidelines for Management of Severe Sepsis and Septic Shock. This is, I'd be remiss if I called it the Bible, but we do have strong evidence-based guidelines. The whole point of this slide is just to show that they reviewed every article ever written on severe sepsis. They graded the article according to how good it is, what kind of a study it was, what kind of a strength of evidence it provided, and then they made recommendations based on the strength of the evidence. Just like any good set of guidelines, that's what they did. Key points that we learned from those guidelines. Number 1, sepsis is time sensitive. Sepsis is time sensitive. It's one of these time sensitive diagnoses. And that, you know what, I think saying it's time sensitive is fairly an understatement. Severe sepsis is an emergency. Plain and simple. It's an emergency just like one of these things. With acute myocardial infarction, Here at KU, we track door to PCI time. In other smaller hospitals farther from a cath lab, you may track time from door to receipt of TPA or other thrombolytic agent. Because we know the faster you get blood flowing through that coronary artery, the more myocardium is saved, the more people survive, and the more likely they are to be able to have normal activities when they do survive. Same thing. We have stroke teams to help us get the TPA into people because we know that the faster that happens in a thrombotic stroke, the sooner the treatment begins, the more brain function one retains, and the more likely they are to survive. We've known about the trauma golden hour for absolutely ever. We know that the faster you get someone for definitive treatment in the trauma center, the more likely they are to survive, and so we do that. Severe sepsis needs to take its place on this list. The faster we act, the better we do. So what is it? I'm going to skip bundling of care for the moment and talk about what our care bundles are. What is it we need to accomplish? Starts with measuring a lactate, which sounds a little bit silly. How can sending a blood test save a life? Well, the truth is we have to have the answer to the lactate when we get down to stage about number 4. So if we don't send it now, we start holding up progress when we get down here. So we send it soon. We obtain blood cultures before antibiotics if possible. We get our broad spectrum antibiotics running in under an hour from the time of presentation. And then here's what we do. If the patient's hypotensive or the lactate's greater than 4, 30 milliliter per kilogram bolus of crystalloid, and vasopressors to get the MAP up to 65. If it takes vasopressors to do that, if they don't respond to the 30 mil per kilogram bolus, we insert a central line, we do a CVP, or we get our CVP optimized, and we measure our central venous oxygen saturation, which I don't have a lot of time to go into right now, simply to say that if it's low, it means the tissues are not receiving enough oxygen via the cardiovascular system. 70% for central venous O2 sat is normal. So what this says is that within 6 hours, we are attempting to normalize central venous oxygen saturation. I'm going to back up here. That seems fairly simple. Measure lactates, draw blood cultures, get antibiotics in, bolus with fluids, get them on vasopressors, make sure their CVP is normal, get their central venous O2 sat back to normal within 6 hours. Conceptually, that's really easy. Just let me ask you here a couple more slides, and then I think I'm going to stop for questions. But here's another question for you. In the early resuscitation of the severe sepsis patient, the most important feature is what? IV fluid boluses, antibiotics as fast as they can get in, measurement of serum lactate, measurement of central venous O2 saturation within 6 hours. I say the answer is this: antibiotics as fast as you can possibly get them in. I'm going to show you some data from a friend of mine named Anand Kumar, who works at the University of Manitoba in Winnipeg. He recruited 13 other ICUs along with his, and they studied 2,731 patients with septic shock. They chose septic shock because they said, okay, we can note in the chart when the first hypotension started in these patients. We want to know, does the timing of the antibiotics after the onset of shock alter the survival? So what they've plotted here is survival rate on the left and time to receive antibiotics after the onset of shock on the x-axis. Remember I told you that Septic shock has a mortality risk of 60 to 80%, which means that its survival rate should be 20 to 40%. So here's what they saw. They saw that if you get your antibiotics in the first half hour after onset of hypotension, your survival went from down here to up here, almost completely reversed. 20% mortality instead of 20% survival. For every hour of delay in administration of antibiotics, mortality goes up by 7.5%. So by the time we get out here to 5 to 6 hours, our mortality is down around, or survival is down around 40%. So here's the striking thing that goes along with this information is that in these ICUs, all of these ICUs being strong ICUs, academic centers across North America who are interested in the treatment of severe sepsis and septic shock, in those ICUs, only 50% of patients with septic shock got their antibiotics in that first 6 hours, which explains a lot about why the historical mortality of septic shock is 60 to 80%. I think that is where I want to stop. What I want you to know, I guess I'll settle in on this slide and just say that there are over 19 studies in the literature now demonstrating that that approach to patients with severe sepsis and septic shock reduces the risk of dying substantially. We've used these techniques at KU to reduce our mortality rate from severe sepsis from a starting mortality of 49.1% down to a current mortality of 17.6% over the course of several years. What I would encourage is that we use our surviving sepsis guidelines for both diagnosis and for treatment of patients with severe sepsis. And I think that's where I'm going to stop now. Any questions from anybody who's out there? If indeed anyone is even left.
Not a word here.
All right. We have, just so you know, we have developed an approach to severe sepsis via something called the Kansas Sepsis Project, where we help folks to assess their baseline care for patients with severe sepsis, and then we provide a database to record how well you do the various components of sepsis care and to track your mortalities and so forth. And if you're interested in that, you can email me at, let me see, is my, oh no, it's, I'm going to have to end the show to get down to my email address. I want to display it. Here it is. Let's put that up. ssimpson3@kumc.edu. Let me know if you're interested in maybe getting your hospital involved in severe sepsis care. We are now in, about 15% of the hospitals in the state of Kansas who are up to using our database, collecting their own data, trying to improve their outcomes with severe sepsis. And we'd love to have even more people join us. Okay, well, if no one has any questions, Julie and Scott, Carrie, I'm sorry, read it backwards, Carrie, Julie and Carrie, if you guys have no one there with questions, then I guess we can go ahead and stop the phone call.
Perfect. We don't have any questions from our end at this time.
Okie doke.
Sure. Thank you.
Thank you all. Sorry I couldn't be there in person.
Oh, no, that's okay. We appreciate the lecture. It was great.
Okie doke. Good. We'll talk to you again, I hope.
Great. Thank you.
Uh-huh. Bye-bye.